Right, so lastly, this is the last slide. I want to talk about incontinence. I want to hit on stress incontinence, and I want to hit on overactive bladder urge incontinence. In a nutshell, the easiest way to, let's look at this reflex urinary incontinence. These diseases here can cause more like a neurogenic bladder, and the simplest way is that your brain, something's malfunctioned in the brain because it talks to your bladder, and so it's unable to communicate accurately, and therefore you don't have any feeling of whether you are urinating or not. So these people have to self-cath. Now, overactive bladder, it's also a communication issue between the brain and the bladder. So for example, if we normally walk around with our bladder somewhat full and you can't really feel it. But with an overactive bladder, this muscle here, remember your bladder's a muscle that has nerve endings, it becomes hypersensitive, and your brain starts telling you that you have to go to the bathroom, even when your bladder's just a little bit full. When before you could probably walk around with your bladder that full all along. But then as we age, is a common cause, our brain and our bladder don't talk to each other as well. And you can start having feelings that you have to go to the bathroom. So if you've seen commercials, gotta go right now, this is overactive bladder. There's a miscommunication with your brain and your bladder. So what do we put patients on? We put them on medications such as antimuscarinics, and Vesicare is one, Enablex is another, Myrbetriq is another. And what that does is help calm down this muscle of the bladder so it doesn't spasm. You can also do exercises. You tell the patient, let's say you wake up in the middle of the night with, you feel like you have to go to the bathroom and you're getting up 3 times a night. You say, okay, wait 15 minutes. And many times this feeling will go away. So there is a psychological component to overactive bladder. Many people, when they drive up to their home, they run in, they got to use the bathroom right away. And it becomes a psychological of your brain and your bladder talking to each other, but it's not normal. Okay, so stress incontinence is actually a mechanical issue, and that's usually from putting so much strain from having children. And again, those ligaments end up weakening. That's holding up the uterus, ends up pushing on the bladder. So you can end up coughing, and this area here, this part of the urethra, every time you cough, it's going to be more lax. That's how I think of it, as being lax. So it's going to open up and you're going to leak urine every single time you cough, you jump, but this is a mechanical issue. So treatment for that is putting a sling in, and let's just say this is the urethra right here. They put a sling in about right here and they attach it. And then when they cough, the urethra bounces on this. It's not holding it up, it's below it. And so it's just enough bounce off of it that they're not going to leak urine, but yet it's still holding it up. You don't want to hold it up like this with the sling right on the urethra, because then they have an increased risk of retaining urine, and you don't want that. You still want it to work naturally. Other methods, surgical methods, they can go in and actually lift the entire bladder up. It's called a sacrocolpopexy. Sacrocolpopec, it's been a long time. I used to be an NP in urology. Sacrospinous colpopexy, I believe that's what it's called. But anyways, you end up just pulling everything up. Many times these women need to have a hysterectomy because everything else is falling down. So if they're finished with family planning, everything's falling, the uterus, the cervix is attached to the uterus and the bladder, they'll do a hysterectomy and put a sling or lift up the bladder so you don't have that problem anymore. So the treatment for stress incontinence is surgical, and I shouldn't say it's all surgical. There are devices that they can put in the vaginal area to try to hold it up, but really it's not as not as efficient, I should say. Overactive bladder medication, and also, which I forgot to mention, there's a stimulator that you can, a nerve stimulator that you can put in the lower sacral area, a bladder stimulator, and calm down that muscle that way too. So if the medications don't work, then insurance usually will pay for the bladder stimulator to go in. There's always a trial that's done first, because you don't want to implant a stimulator with leads and implant into it's implanted in the butt cheek area, and the leads are to the sacral nerve area. If you don't want to implant that if it's not going to work, so they usually do a trial with external leads. The patient goes home for 48 hours and does different settings to see if it helps their symptoms. If it does, then they'll go ahead and do a permanent one. All right, and that is it on renal pathophysiology.